All right, let's get this show started. Good evening, everyone. Welcome to the seventh mini medical school of 2021. Hard to believe there's been six already. My name is Zoe Burrow. I'm a first year student at the IU School of Medicine, and I'm going to be one of your co-moderators for the session tonight.
Hi everyone, my name is Natalie Cox. I'm also a first year medical student with Zoe, and I'm going to be another one of your co-moderators for tonight.
And if this is your first mini med school in 2021, you may have noticed the format has changed a little bit because we're holding it over Zoom, but we are so happy to have you here with us tonight virtually. Before we introduce our panelists this evening, I'd just like to take a moment to thank sponsors who have made the 26th annual Mini Med School series possible. So a big thank you to Hamilton Center, Inc., Indiana State University, Indiana University School of Medicine, Terre Haute, Lugo Center for Rural Health, Minority Health Coalition of Vigo County, Inc., Terre Haute Regional Hospital, Tribune Star, Union Health, Via Media, West Central Indiana, AHEC, and WTHI-TV.
And if you are new to this series or it's been a while since you've attended one, I'm just going to explain the logistics for tonight's event. So we're using the Zoom webinar platform, and that will allow us to hear from our local expert panelist, but keep all other attendees on mute. So throughout her presentation, it would be great if you can submit questions. There's a Q&A button at the bottom. When you submit those, they'll populate to us, and at the end of the presentation, we'll take a brief intermission and then come back and answer those questions. So tonight's topic will focus on wellness and mind-body connection.
And our panelist for this evening is Tasha Newcomb, LCSW. Tasha is the Executive Director of Addictions and Substance Abuse Services and the Director of Inpatient Social Work at Hamilton Center, Inc. Tasha is also an adjunct lecturer at Indiana State University for the Social Work Department. Tasha obtained her Bachelor of Social Work degree in 2009 and her Master of Social Work degree in 2016. Her experience includes working in a long-term facility, providing social services to the older adult population, with a specific interest in older adults with mental health diagnoses. She has previously worked as a therapist at Hamilton Center's subacute unit and inpatient unit, working with consumers with acute and chronic mental illness. Currently, she oversees addictions programming and implementation for Hamilton Center and provides individual and group therapy for consumers who are duly diagnosed with a mental illness and substance use disorder. Without further ado, Tasha, please take it away.
All right, thank you. I'm going to do my best to share my screen here. See if I can. Okay. It's working there. Can you see it okay? Okay. Okay, so as Zoe and Natalie mentioned, I'm going to be talking to you a little bit about wellness and the connection between the mind and the body. Maybe. Oh, there we go. Okay, so some of the learning objectives for today are to gain knowledge of the interdependence of mental and physical health, so that connection between our mind and our body, and then increasing, oh, let me see here, I'm frozen. Okay, increasing the understanding of common mental illnesses and physical health. Sorry, I'm having a couple issues here. There we go. So increasing the understanding of common mental illnesses and physical health that may be present. So I'm going to start off by talking just about some common mental health diagnoses that we see. And we see a lot of these in both mental health treatment and also when we are working with individuals on their physical health. So the first mental health disorder that I will talk about is depression. Some of the common symptoms we might see when working with someone who has depression, that depressed mood, feeling sad, feelings of hopelessness, loss of interest or pleasure. So that is somebody has, maybe hobbies, things they enjoy doing, and we really see a marked reduction in how often they are participating in those activities. Weight loss or weight gain, Insomnia or hypersomnia. So insomnia, we know, is the inability to sleep or inability to obtain enough sleep to feel rested. Hypersomnia then is the opposite, where maybe somebody is sleeping more than usual. Maybe they sleep all night and then sleep for long periods throughout the day. Fatigue, decreased concentration, and then thoughts of death or suicide. The next common mental health diagnosis to discuss is anxiety. So we see excessive anxiety or worries, nervousness, maybe restlessness or feeling keyed up or on edge. So inability to rest, right? Frequent moving, fidgeting, being easily fatigued. This is something that goes with both depression and anxiety. Again, difficulty concentrating goes with both depression and anxiety. Also with anxiety, you may experience the mind going blank, just inability to think or focus on anything sometimes. Irritability, so easily upset, maybe frustrated easily. We also do see some irritability with depression at times. Muscle tension. A lot of people who experience anxiety feel tenseness maybe in their arms, in their hands, in their feet, maybe some clenching of the fist. A lot of times we will see that, and also in the neck and back. And then again, sleep disturbance, so difficulty falling or staying asleep, or feeling restless or experiencing unsatisfied sleep. A lot of the sleep disturbance that we see with anxiety comes from that excessive worry. A lot of people with anxiety will express having, kind of racing thoughts when they try to sleep, or inability to shut off their mind. And then insomnia. The important thing to know about insomnia is insomnia can actually be a symptom of other disorders. So difficulty initiating sleep, difficulty maintaining sleep, and this is frequent awakenings, or somebody who wakes up, maybe they've slept 3 hours, they wake up and then they are unable to go back to sleep. And then again, early morning awakenings with inability to return to sleep. What's important to note about depression, anxiety, insomnia, as I said, insomnia may be a symptom of anxiety of depression. You may also have some overlap of symptoms with anxiety and depression. A lot of times, we have to really vet out those symptoms to ensure, is this anxiety, is this depression? The way we really do that is looking at, for depression, is really that low mood, that loss of interest, and those feelings of sadness and hopelessness, and then again, the thoughts of suicide. So that's really what we're looking for when we're looking for depression versus anxiety. Some common gastrointestinal issues, and I will say that we see these, we may see these with anxiety and depression. Bloating, constipation, diarrhea, heartburn, incontinence, nausea and vomiting, and pain in the abdomen. We do see nausea and vomiting pretty frequently in folks who have severe anxiety. Diarrhea as well, that nervousness, we will see that. Also, incontinence, believe it or not, one of the signs of anxiety is increased need for urination. So we do see that at times in folks who have severe anxiety disorders. I'm going to now move to talk a little bit about some common physical health diagnoses. And when I say common, these are disorders that we see frequently maybe in the population that we're serving, those folks who we serve for both mental health and also primary care reasons. So these are some of the more common diagnoses that we see. So the first one is chronic obstructive pulmonary disorder, or COPD. And the main symptoms we see with chronic obstructive pulmonary disorder are shortness of breath, especially during physical activities. We see a lot that folks, maybe even just walking short distances, becomes hard for folks who have COPD. We see a lot of wheezing, chest tightness, chronic cough that may produce mucus. It may be clear, white, yellow, or green. And I will tell you, in working with folks who have COPD, if you've worked with those folks long enough, you can kind of identify that cough. It's a very distinct sounding cough. And also then frequent respiratory infection. So do people get colds frequently, an upper respiratory infection? People with COPD also are prone to getting pneumonia more easily than the general population. So that is something that we may see as well. lack of energy. Again, if you're having frequent shortness of breath or inability to catch your breath, that's very hard on your lungs. It's very hard on your heart. So that can then cause you to have less energy throughout the day. And then unintended weight loss. So we typically will see this in later stages of the disorder. Some of the common contributors that we see, I will tell you the most common contributor to COPD that we see in the population we work with is smoking. Another is asthma. Folks who are 40 and older are more susceptible developing COPD versus the younger population. Pollution is a factor, chemical exposure. We do see COPD, people, older adults who maybe worked in coal mines, that pollution, maybe people who were painters or worked in areas where there are a high level of chemicals. Later in life, we see maybe develop COPD. AAT deficiency, and then folks who have chronic bronchitis are also more susceptible to developing COPD. One of the other more common disorders that we see, and we do see diabetes again pretty frequently in the population that we work with, is, I already said it, diabetes. So some of the common symptoms that you may see associated with diabetes are feeling tired and sleepy, blurred vision. As we know, sugar levels can affect eyesight, so we do see that pretty frequently for folks who are not controlling their sugar. Confusion or passing out, being very thirsty, sweet smelling breath, and some of it sometimes described as smelling like nail varnish or pear drop sweets. Stomach pain or feeling or being sick, high blood sugar levels, and then needing to urinate more often. Again, as I mentioned with COPD, the population that we serve, so folks who have chronic mental health disorders and then chronic physical health disorders, a lot of times don't have a proper balanced diet. It may be because income, it may be because of living situations. Also, we know that certain medications used to treat mental health disorders also cause increased appetite and weight gain, and then we may see diabetes start to develop later on as a result of that. As I talked just a little bit ago about some of the common GI symptoms that you might see with anxiety and depression, I'm going to just give a little bit of a background on that. So our brain has a direct effect on our stomach and our intestines. One study by Akram in 2021 identified the unexplained physical complaints as a whole. So these include fatigue, headache, stomach upset, nausea, diarrhea, constipation, dizziness, and musculoskeletal pains are more commonly reported in individuals with an anxiety disorder and or depression. So again, just to reiterate what I said a little bit, folks who have a mental health disorder are more susceptible than to having physical complaints than somebody who does not have a mental health disorder. As I said, the brain really has a direct effect on the stomach and the intestines. So our gastrointestinal or GI tract is very susceptible to emotion. Feelings like anger, sadness, anxiety, and elation, they can trigger symptoms in our gut. I know, nice word, but, and that was identified by Harvard Health. And really, thanks to Harvard for producing this research, but I can tell you just from firsthand knowledge, it's not uncommon to have somebody come in who's explaining symptoms of anxiety or depression, and we might hear things such as, you know, I get an upset stomach, or I don't have an appetite, or I feel like I have to go to the bathroom more frequently, or I feel like I can't have a bowel movement when I'm anxious, right? So we hear these physical symptoms reported day to day in folks who have anxiety and depression. So this research really solidifies what we're hearing from day-to-day reports from the consumers that we serve. Just to note, it's difficult to heal a distressed gut without considering the role of stress and emotion. So you will see more and more frequently, and I believe it may even be a standard now, that physicians are asking questions. They're doing what we call the PHQ-9, which is the depression screener, and the GAD-7, which is an anxiety screener, to help identify some of those mental health symptoms, because as research continues to grow in this field, we are increasingly seeing more and more that that connection. So it's very important to identify how emotion and stress may be playing a part in the physical symptoms that we're seeing some of those consumers or patients come in with when they enter our offices. Next, I'm going to talk about anxiety, depression, and COPD. So two of the most common and least treated comorbidities in the United States are COPD, are anxiety and depression. So both are experienced as common comorbidities of COPD. Approximately 60 million people in the United States live with one of 4 chronic conditions. So heart disease, diabetes, COPD, chronic respiratory disease, and major depression. So that's a quarter of the population, or 60 million people, I'm sorry, live with one of these 4. So that since at least 60 million have one of these, and we know there's a correlation, then a good percentage of that number are going to experience some sort of depression. As I mentioned earlier, COPD causes shortness of breath, and when the body experiences that, it sends distress signals to our brain. Sometimes those distress signals may cause a panic attack or exacerbate our symptoms of anxiety. I will tell you, this is not uncommon in folks who have COPD to then experience a panic attack or anxiety. One of the main factors we of course see with COPD is that shortness of breath. And when we become short of breath, our body kind of takes over, right? And that's what this is talking about, those distress signals. So oftentimes when people are having that shortness of breath and they have the panic attack, a lot of people feel like they are not going to be able to catch their breath. I've had people explain to me that they feel like they are dying because they cannot catch their breath. But what happens in a panic attack for somebody who already has trouble breathing, often we see in a panic attack and somebody without COPD that they then become more short of breath because they take slower, faster respirations, which then becomes harder for them to catch their breath. And if you have somebody with COPD who already has this, the panic attack has a bigger impact on somebody with COPD because they're already experiencing that shortness of breath. And they already have that difficulty taking those big, deep breaths because of the state of their lungs. So really, we have to be very cautious in this event because it can cause, oxygen levels to drop. A lot of times you will see folks who have COPD, maybe they have a PRN or an as-needed anti-anxiety medication to help them keep calm so that their breathing can stay more regulated. Overlapping symptoms of depression with COPD include sleeping or eating problems, fatigue, and feelings of frustration or sadness. Somebody with stable COPD, the prevalence of clinical depression is between 10 to 42%, while that of anxiety ranges between 10 to 19%. One thing to think about in consideration here when we're talking about COPD is COPD does progress over time. And COPD, when somebody's in later stages of COPD, it really becomes, it gets to a point where it's not treatable. So when somebody gets to end stage COPD, really it's about helping them maintain comfort. A lot of times we'll see oxygen used. So to think about that and just the impact that COPD has on a person's body, right? They're in the impact on mobility. It becomes difficult to walk even short distances for some folks. A lot of folks end up on continuous oxygen when they have COPD. So that can be a hindrance when you're trying to travel and go places you previously enjoyed, right? And the anxiety of thinking that you're not going to be able to breathe, right? So all of those things become such a big lifestyle change for a lot of folks that we start to see that sadness. When people get to the later stages, we start to see that hopelessness set in. I've experienced people who have COPD say that they get to a point where they don't want to have to live like that anymore with the breathing treatments, the oxygen, the medication that's required to assist them in breathing. So it's not uncommon or certainly not, I guess I'm trying to look for the right word here. I'll put it very simply, I guess, as a therapist, it makes sense to me that we would see depression and we would see anxiety in someone with COPD because the big impact that it has on a person's life and a person's functioning. The next part I'm going to talk about is diabetes and depression. So according to the CDC in 2021, so just this year, people with diabetes can experience, are at double the risk of developing depression in comparison to the population that does not have diabetes. And damage resulting from diabetic neuropathy or blocked blood vessels in the brain may contribute to the development of depression in people with diabetes. Also, changes in the brain due to depression may cause an increased risk for diabetic complications. Symptoms of depression can make it more difficult to successfully manage diabetes and prevent diabetes-related complications. Sorry about that. So some common symptoms of depression that we may see in people with diabetes, and again, this is important to think, and when I talked earlier about ruling out, right, is this depression anxiety, or is this more of a medical issue? One of the common things to think about is with diabetes, you may see a change in appetite, right? Increased appetite or decreased appetite. One of the things to think about is, that's also a symptom of depression. So this is where it becomes very important to screen that out, right? Are we experiencing, not we, but the person, experiencing those symptoms of depression because of diabetes, or are they experiencing those symptoms of depression because they had depression maybe prior to, or are they depressive symptoms at all, and are they related to more of to the diabetes? In my experience in working with folks who have depression and diabetes, one of the common things that's been identified by some of the patients is that inability to feel like they have control of their lifestyle, right? They can't make choices in regards to diet, or they feel like they can't make choices. Let's put it that way. We know that there are choices to be made in regards to diabetes and diet, but folks saying, I feel like I can't eat the foods I used to be able to eat, right? I can't eat the foods that I enjoy. I also have had some folks who have maybe later developed type 2 diabetes, and quite frankly, some of that is a result of lifestyle. I do see some feelings of guilt at times. I've gotten to this point in my life and now have diabetes because I wasn't taking care of myself. I wasn't exercising as I should. I wasn't watching my diet as I should. So there are some feelings of guilt that we see in people who have diabetes. Feelings of guilt can lead to then later on some more symptoms of depression. So that is pretty common. And as later stages or untreated diabetes, we know can affect, again, that mobility, as with COPD. For people who develop neuropathy, can make it very difficult for them to ambulate at times due to the pain and numbness that they have in their legs. People's handwriting may become affected due to the pain and numbness maybe they experience in their hands. Eyesight becomes impaired, which then can trigger depression. And a lot of folks, because they're not able to see to do things that they previously enjoyed. And then we almost kind of see this cycle of grief sometimes as people start to lose some of those abilities that they had prior to. We see kind of a cycle of grief start to develop in some folks with some of these disorders as well. Insomnia and gastrointestinal issues, or GI issues. As we talked earlier about the connection between the gut, as I said, and depression and anxiety, that's also common with insomnia. There's a significant association between disturbed sleep and GERD, and it may be bidirectional. So gastroesophageal reflux disease or disorder, I think I said that, I kind of butchered that, but so I'll just go with GERD. But sleep disorders may actually induce GI disturbances, and GI symptoms also provoke or worsen sleep. So for somebody who may have reflux or gastric acid present, they experience issues with sleep because it becomes uncomfortable, right? So reflux of gastric acid is a less frequent event during sleep. However, acid clearance mechanisms, including like swallowing, salivation, and primary esophageal motility, are impaired during sleep, which results in prolongation of acid contact time. We see, for people who have acid reflux or who have GERD, a lot of swallowing. People may talk about, they can feel the acid, or they have heartburn, or they can, it's difficult for them to lay flat. Some, we've had people say they can't lay flat because of this. Some people have to sit up. We have people a lot of times who will talk to us about frequently getting up in the night to, maybe they're taking a Tums. I've had folks tell me they get up to drink a glass of milk, but really impacts their sleep and makes it hard for them to fall asleep or stay rested. So we do see that a lot with folks who have GI issues, that insomnia, and it may start out as, just sometimes I wake up here or there, but we have seen it get to the point where people have difficulty falling asleep at all because they really just cannot get comfortable. So this is not uncommon with people who have GI issues. Again, something to be mindful of when we have patients with GI issues is really talking to them about how it impacts their sleep. What we also know for people who have insomnia or trouble sleeping, as we said earlier, may then go on to also show those symptoms of depression or symptoms of anxiety due to the extreme fatigue that they're experiencing from not being able to sleep. A lot of times, people who have insomnia have difficulty focusing the next day because they did not get a good night's sleep. Excuse me. They may have trouble engaging in activities that they enjoy because they are exhausted. And then we can kind of start to see that morph into depression a little bit too. So definitely something to be mindful of here, something to really make sure you're vetting out when you're working with a patient, or if you're a person who is experiencing GI issues, having that conversation with your physician to say, this is really how it's impacting my sleep. I'm not feeling rested. I'm not feeling like I'm getting the rest that I need to then carry out my responsibilities the next day because of the severity of my symptoms. And that really, I know, short presentation this evening, but that does conclude just the overall topic of discussion on the common mental health disorders and physical health disorders that we see. This ending slide here is our number at Hamilton Center for Referrals. It's 812-231-8323. And then, of course, our website. I think most people are using those these days. So if you have any questions or feel like you may be experiencing some of these symptoms, we, always have somebody available when needed to, complete an assessment or just talk to somebody if needed. So feel free to reach out. And there's a way to reach out via the internet or via the website on the internet as well.
Tasha, thank you so much for that presentation. For our attendees, we're going to take a 5-minute intermission. During break, a pop-up window will appear on your screen just to collect some basic demographic information. If you don't mind completing that poll, that would be wonderful. And then after the 5-minute intermission, we will resume for a Q&A session. So we'll see everyone back in about 5 minutes, and please fill out that poll if you don't mind. Thanks.
And then we'll get started on some questions. I think we've got a couple here hanging out in the Q&A. So attendees that are here, please feel free to continue submitting questions using that Q&A feature down at the bottom, just as they come to you. But we'll start with the questions that we have in the Q&A. So the first one, and I think this was in relation when you were discussing anxiety and depression at the beginning, was what is an AAT deficiency?
Yeah, so I'm going to do my best to say this word. So this was actually in relation to when I was discussing some of the contributing factors for COPD. So I'm sorry if you can hear my dog, I apologize. So that's the Zoom world, right? Everyone's got a dog or a cat or something. So it's alpha-1 antitrypsin deficiency. So I hope that I said that correctly. I don't know that I did. It's basically a condition in which the body does not make enough of AAT. It's a protein that protects the lungs and liver from damage. So when somebody does not make enough of this protein, they are more susceptible to then developing COPD because they do not have enough of this protein to protect their lung and their livers in comparison to somebody who normally develops this protein. I'm sorry, I can hear her out there.
No, you're fine. Thank you so much. And we have another question that says, with COVID-19, how are mental health providers assisting people with raised stress levels that they might be experiencing?
That's a good question, and actually a question that, oh my goodness, hold on one second, please. I apologize about that. So that's a good question, and a question we've been getting pretty frequently. I will tell you, we are already, well, not already, I guess it's been a year, right? We're a year into this, over a year. And I will just start by saying that I don't think any of us were prepared or believed that we would get to this point, right? I think most of us went into the health emergency thinking it would be short-lived, or, once we, put some structure and routine in place, we would be able to get back to a fairly normal way of life. And so as this has went on, the longer it's went on, the more of an impact we have seen on people's mental health, and then also on people who maybe have been in recovery from substance use. Early research is starting to come out that more people are using substances than they were prior to the pandemic, or people who maybe had maintained periods of sobriety have since relapsed and are now back in active use. We also have seen an increase in the number of suicide attempts and completed suicides, particularly in the younger population. We have seen an increase in assessment for people with suicidality. A lot of what we're seeing has to do with the lack of connection, feeling isolated, lack of access to activities that may have previously been used for like a coping skill, right? I go to a cooking class every week because that helps me maintain a routine, and I have a connection with the other folks there, and that's how I stay connected. And so we've really seen that impact. One of the things that we're doing to help people manage stress is to help identify what is in our control right now. Because I think a lot of us have felt during this time that, we don't have any control of our life. We can't go here. We can't go there. You have to wear a mask. You can't be in a group larger than 10, and we know why that's happening. We know that it's imperative to follow those guidelines for our safety and the safety of others, but that still can become very difficult. So we've been doing a lot of, helping people identify what's in their control, and adjusting to a new way to become involved, right? We've really implemented a lot the use of technology in what we do as mental health providers. And then also now providing online resources then for our consumers to use as well, helping people get linked up with sites where they can get a free phone or phone minutes or an iPad, or helping people identify places in their community where they have free Wi-Fi where they can go and spend time to have that connection. We've also really done a lot of just processing. How has this impacted your life, and just that reassurance. Sometimes it really helps people to just know that they are not alone, right? I'm a therapist, but I'm impacted too, just like you are as the consumer who's coming to see me. So normalizing that a little bit. It's okay to feel disconnected. I think this is a time when we all feel disconnected, and letting people know it's okay to feel that. But definitely something we keep on our radar. Definitely, something we are being sure to ask our consumers when we're talking to them, how are you doing? Really doing that check-in with them. But I think that one thing I think that we all need to be aware of is I think we're going to see the effects of COVID-19 even farther down the road, right? Because we're going to start to see the effects of children who didn't have socialization and older adults who didn't have socialization. And how does a child develop in kindergarten that went to school and couldn't see their teacher's face for a year versus a child who had full access to emotional response? So we're going to see things even continue to come further down the road. I think we're just now seeing the beginning of some of the impact.
So I think that's definitely so true. At least for Nat and I, this is our first this past semester was our first semester of medical school, and it was completely online, and just completely changes, I think, your perspective on what school looks like. We do have one more question in the chat. It's not related to your presentation so much as if you could share your screen one more time and pull the title page up of your presentation.
Oh, I will do my best. Well, that's not the title. Here we go. Can you all see that okay?
Okay, at this time we can ask if there are any other questions people want to submit. Please go ahead and submit. The Q&A box should still be open, so we'll give you a couple more seconds if there's anything burning in your brains that you want to ask.
I would say I had a question, and I was just kind of curious from your perspective. Things have certainly changed a lot in the last year, and especially with just in terms of reaching out, getting help, talking to people, and a lot of that has been, I'm assuming, online over formats like this, like Zoom. Do you think people are finding it more difficult? Is it easier to reach out and start talking to people? I don't know. What is your take on that?
Yeah, so great question. I will tell you that's also a very popular question, because I think we want to know we're being effective, right? As practitioners, as future physicians, or whatever path you go down. You want to know you're being effective with the person you're working with, right? And not only just with clients or consumers or patients, but with your coworkers and your colleagues as well, right? We have had, I will tell you, mixed feelings. The one thing I will say that's definitely been a positive for us is the use of telehealth. We have been able to reach more consumers and serve across the population, or across the area, more people than we have served in previous years. We've been able to reach people in more rural settings who maybe have transportation issues that can't get them to the office. But then we've also seen challenges where people in rural settings can't use telehealth because they don't have fast enough Wi-Fi to access, right? So it's really, I think, as a society, helped us to identify some of those, some of the impacts of living in rural society, some of the impacts of living in poverty, or in an underserved area, or being part of an underserved population, and that not everyone even has equal access to internet, something that is all over the place and we take for granted, and we can get on our phone at any time and look at something and the answer's right there. Not everyone can do that. So it's made us be more cognizant of that, which I think is important. But I will tell you, just myself personally, I can see it going both ways. I think for the, one of the things I talked about earlier were those people with substance use disorders and the number of relapses. There was a distinct missing connection from those in-person meetings that I saw from the folks that I work with. Being part of a recovery community is so important for people who have an addiction. And there was a period of time where they could not go to meetings in person. There were online meetings, and we helped facilitate that. And we moved all of our groups to online, and we had folks really come and participate. But consistently, I heard, this isn't the same as me seeing them in person. This isn't the same as me seeing them in person. And I heard that more with that population than I did with people who have just a mental health disorder. I will tell you, I have some consumers who are like, I don't care if I ever see you again. You can call me once a week. It's fine. I don't need to see you. If I need something, I'll call. And they've been okay with that. I think we have to be aware that even though we offer telehealth services or virtual services, we still have a responsibility to know that that's not for everybody. That we have to vet that out and really know our consumers and know our patients, and determine, is a phone call really going to be enough for this person, or is this somebody I need to schedule to come into the office and see me because they need that level of connection, right? And conversely, is this person, again, somebody who never wants to see my face again, and I can just call them and it will be okay. I think we have a responsibility to know that, and to then provide that service in the best on the best platform that's best for our consumers. We have maintained throughout the health emergency the ability to request face-to-face appointments, and any consumer that's needed to be seen face-to-face, we've made arrangements for that to work. So really just knowing your consumer, and then knowing those areas where it's not possible to meet with someone like that, and being willing as a practitioner, a therapist, a doctor, whatever word you use to describe yourself, to meet your consumer where they're at. That's always what we have to be mindful of and be willing to do to be able to serve. So.
Absolutely. Thank you so much.
You're welcome.
Okay, Tasha, I think that is all the questions that we have had. Is there anything else you want to say before we wrap things up?
I don't think so. Thanks for having me. I always enjoy doing education, and so I appreciate the opportunity.
Yes, well, thank you so much for being here. So that will conclude tonight's mini medical school. Thank you, Tasha, so much for taking time to share with us the information that you have and the resources. And thank you to all of our attendees for joining us and sharing your questions. Just a reminder, mini medical schools are every Tuesday for the remainder of April. They're 6:30 to 8:30. It's the same Zoom link each week, so just hop back on. The next topic on next Tuesday will be on joint pain. So if you're interested in that, please jump on and tune in. If you've missed a session and you're interested in getting that info, there are recordings for the sessions posted on the website, I believe under the date of the talk that you missed. And finally, when this meeting ends, a survey will pop up with just some basic questions. They're going to be different than the questions from the intermission, and your feedback is completely anonymous. It's just over the talk and hopefully some information we can use to keep improving our sessions. So thank you again to everyone for joining. Thank you, Tasha, and I hope everyone has a wonderful night.
Thank you.